So, my agenda today will be the different conditions that we encounter, the preoperative history and examination, which is important, the investigations that we need to do actually, and the anesthesia considerations. Now, I have written the different diseases because we encounter all of this, though the symptoms overlap, the investigations nearly are the same, like chronic bronchitis, asthma, bronchiectasis, interstitial lung disease, emphysema, pneumonic patch, which is there, fibrosis, and acute respiratory infection and ground glass opacities, which was common after COVID. Now, today here we are there to understand how respiratory diseases affect our anesthesia management. But even if the patient does not have respiratory diseases, we are aware that already our anesthesia is compromised and the respiratory system during anesthesia and surgery is already compromised when we are giving anesthesia. Some surgical procedures which require surgical retraction of the abdominal wall of the thoracic wall or surgical procedures which require Trendelenburg position, lateral positions. Surgery itself produces an inflammatory response, and inflammatory as well as pain mediators are released which act on the bronchial wall. We have laparoscopic surgeries with pneumoperitoneum. The list is vast and we all are aware about it, that whenever there is different types of surgeries, we have to be vigilant that it is going to cause lung atelectasis in some way or the another. Also, our all anesthesia drugs, we are aware that they decrease the drive to breathe. They decrease our response to carbon dioxide and hypoxia, be even it a small case under total intravenous anesthesia. There is an important article, as we all know, that difficult airway mandates us to pre-oxygenate the patient with 100% oxygen. But remember how much is adequate pre-oxygenation for 3 minutes, and to achieve an EtO2 of 90% is adequate. The moment 3 minutes are over, you may start air oxygen or nitrous oxygen, because then the absorption atelectasis starts, and hence we should be aware that how much adequate is required. Of course, sometimes when we try to be lung protective and give low tidal volume, 6 to 8 ml, but for 80 kg, if you just give 440 or something, then it will be inadequate. So our small maneuvers in routine anesthesia also may compromise the lung function other than the lung diseases. As we are aware, age increases, small airway closure occurs early. Frailty, which is very nice identity, which is identified recently, increases the postoperative pulmonary complications, the PPCs. Of course, now today we are going to see more about COPD and interstitial lung disease, how they cause atelectasis, smoking and tobacco consumption cause the neurological diseases which cause airway inflammation, and of course, our other physiological conditions such as pregnancy, pulmonary hypertension. So here we have chronic bronchitis and emphysema, which are very commonly called as chronic obstructive pulmonary disease. Now, chronic bronchitis is characterized mainly by the symptoms, such as productive cough, and emphysema is mainly by the structural changes where we have the enlarged spaces in the alveoli. Now, as we see in the diagram, the upper figure is of the normal airway. In the lower figure, we can see the yellow secretions which are blocking the airway in chronic bronchitis, and eventually we can see dilatation of the distal alveoli. So, chronic bronchitis and emphysema come together sometimes, hence we have chronic obstructive pulmonary disease. What is different in an asthmatic patient? In an asthmatic patient, we see that not only the alveoli, but the bronchial smooth muscles, they also become tense. They decrease the bronchial airway, the lumen of the bronchial airway is decreased along with excess secretion. And hence for these patients, pump is very much, the aerosol pump, the bronchodilator pump is very much effective. And of course, the third variety is something called as interstitial lung disease, which also includes pulmonary fibrosis. Here the alveoli, the bronchioles may be normal, but the interstitium between them becomes fibrosed, and hence naturally there will be pressure from outside on the alveoli, and expansion of the alveoli will be affected. Let's take prototype case. Male 60-year-old, hypertensive since 20 years, on treatment, comes for fitness for laparoscopic cholecystectomy, which is the commonest surgery. Further, gives history. We never have a patient giving history of chronic bronchitis. We have patients giving history of asthma, दमे का बीमारी है, but chronic bronchitis and Hardly in 20 years, I had only one patient saying, I have been diagnosed COPD with shortness of breath since 5 years. So any patient who says cough बार बार आता है, कभी थोड़ा दम लगता है, हाँ एक हाथ माले में भी दम लगेगा, in those patients, we should ask, is at present do you have cough? Is the cough wet? Is there any sputum? What is the color of the sputum? We are trying to understand whether he has superadded infection. Is the cough aggravated by dust, perfume, fumes, cold air, seasonal variation? We are trying to understand whether it is just inflammatory and reversible like an asthmatic patient or use of inhaler regularly. So it is better that our PAC book, our PAC paper has this area where we write what is the characteristic of cough, what is the aggravating factors, so that we do not forget asking it. There are a lot of medications with different trade names which the asthmatic or the chronic bronchitis patient is on. But we should be always Googling the name and finding out whether there is bronchodilator, which is theophylline, amphophylline, which is there. They require a bronchodilator. They require, suppose they are in acute infection or secretion, they require a mucolytic, which is on them. Either they will have a short-acting bronchodilator and antimuscarinic agent, or they will have a longer acting bronchodilator and an antimuscarinic agent. I have just enumerated so that we are aware that the patient should be on this. Sometimes we feel that the inhaler is having steroids, but if not, then we should refer to the pulmonologist so that at least a perioperative steroid can be started. Also, we have the latest, if you see steroid and bronchodilator inhaler, then we have fluticasone and umeclinidium and vilanterol. What are these different names? They are nothing but beta-2 agonist plus antimuscarinic agent plus steroid combination, which works very well and used for a long term as well as when there is exacerbation, it works very well. So remember, we should know what exactly the patient is on and what needs to be added perioperatively. Then, of course, nebulization should be given in a case where there is acute exacerbation. Then the latest phosphodiesterase inhibitor, roflumilast, which is there, that nebulization can be given. Patient could be on mast cell stabilizer. Now, if you feel that the patient has superadded infection, refer him to a physician to start the appropriate antibiotic. Oxygen therapy. I remember one female patient many years back, she had come for laparoscopic cholecystectomy and I had asked her, she said, I have cough frequently and I take pump. So she looked so comfortable, but still I happened to ask her, do you take oxygen therapy? Do you take BiPAP, CPAP? And she said, yeah, every night I'm on oxygen therapy. I'm with nasal oxygen 2 liters per minute throughout the night. So always try to elicit the history of oxygen therapy, BiPAP, CPAP, so that when the patient is coming out of anesthesia, we know that whether the patient will require support for ventilation, whether the patient will require non-invasive ventilation and how much oxygen. And of course, some old patients or a patient having chronic sinusitis have taken vaccines of influenza and pneumococcal. Now, it is important for us to understand the episodes of exacerbation which are there. If the last episode is being recent, that means the patient should have been controlled on more steroids, more bronchodilators, and more of drugs which the patient is already on. So we are aware that the acute episode airways are inflamed at least 2 to 4 weeks past the previous episode. The most important, what we are taught and what we do for every patient is the med score. Now, what is this med score? So, med score, as we all know, that if the patient is able to do his regular activity at home, the score is at least still 4. If he is able to climb stairs, run, then the score is 4 to 9. And if he is able to do strenuous exercise, then it is more than 10. It is very important to know that even a high-risk patient, a COPD patient or a cardiac patient with good med score, with good functional ability, behaves well perioperatively because his his cardiac system and his lungs are trained to strenuous activity. Then, of course, association of med score, as I have written, along to the functional capacity. We have various numerous scores. A score like Darcy score is there, where you ask different questionnaire. Again, same to find out the functional capacity. So asking about med score and the functional capacity is very, very important. Of course, NYHA classification is nearly the same, where dyspnea is at rest, dyspnea at minimal exertion, or moderate exertion or dyspnea continuously, history of smoking, tuberculosis, and pneumonia. Just to complete the list of symptoms, which is common, which we were taught during our MBBS time, we have blue bloaters and pink puffers. So basically, they have symptoms of chronic cough with or without expectoration, dyspnea will be present, and wheeze will be present. So this is the triad of chronic bronchitis. In emphysematous patient, what is happening? We are trying to puff out the hyperinflated alveoli, the air trapped in that, and hence they are pink puffers. They have pursed lips. They have increased the accessory muscles of respiration. So we should try to take 2 minutes to elicit whether they have all these symptoms. We don't actually get time during our pre-anesthesia checkup OPD, do a 6-minute walk test or ask the patient to do a stair climbing in front of us. We rely on what history the patient gives us. But if you want to start a dedicated OPD wherein a COPD patient comes and you have a staff who will take the patient for a 6-minute walk, then it is nothing like that. And the importance of that we saw during the COVID scenario. So if the patient can walk 400 meters and more, it is good enough. But if the patient cannot walk more than 100 meters, becomes breathless, then it is alarming. Similarly, for 12 stairs, if the patient takes more than 25 seconds or 26.5 seconds, then it is alarming. Previously, I remember 10, 12 years back, we used to do cardiopulmonary exercise testing. Maybe even I have done for myself. So that is a good investigation, but nowadays it is fading because of the equipments which are required and the cost of the equipments which are required, which actually tells us how much is the peak oxygen consumption during the exercise and its correlation with carbon dioxide excretion. Now, again, this test, you can see any postgraduate student, he will be pit pat with this test. But how much should we follow and what should we do in our PAC OPD? What I do is the breath holding test, the Sebra's single breath count, where I ask the patient to take a deep breath and I start counting how many seconds that patient can take a deep breath. And usually 30 to 40 seconds is normal deep breathing for that patient. Now, what does it signify? If you see on the right side, if the breathing is less than 15 seconds, then the vital capacity is very low. That means with slight insult during the perioperative period, this patient can go in hypoxia, maybe during induction or maybe during positioning on one side or Trendelenburg position or during reversal. Also, the cough test, I don't know how much it is advisable if the patient has acute infection, but I do advise the patient who says I have repeated in upper respiratory tract infection and bronchitis that look on the other side and cough. Try to initiate the cough. So while coughing, the patient has to generate thrice the vital capacity. So it also tells about the respiratory muscle function. So these two tests regularly I do. Of course, the match blowing test, the forced expiratory time test is also very important, where you ask the patient to do a forced expiration while putting a stethoscope on the trachea. But there is observer variability could be there. Of course, if it is very much obstruction and you see a prolonged more than 6 seconds, you can make out that it is an obstructive patient with obstructive lung disease. So ideally, we can go back to basics at our OPD level to find out how much it is. So on X-ray chest, you will find a reduction in the vascular markings, and an emphysematous patient, you will find hyperinflated chest and flattening of diaphragm. But at the same time, the mediastinum, you will find slightly enlargement that could be because of the pulmonary hypertension. And if you see the CT chest, HRCT is basically done to know the stage of the disease. Then here you will find that there is loss of the alveolar spaces, there is loss of the air spaces which are there. Why should we do ECG? Of course, we do for every patient about 30-35 years of age, and a 2D echo. ECG will tell us whether the right ventricular hypertrophy is there because of cor pulmonale. Also, 2D echo will tell us the pulmonary hypertension and right ventricular dysfunction if it exists along with the lung disease in spite of normal cardiac function. Now, the ABG we have been learning since our MBBS, MD. We know, at least we should know the basic ABG of respiratory acidosis and metabolic acidosis. So I have put a very simple ABG where the pH is being maintained. But if you see in the first ABG, the PCO2 is reaching nearly 60 and the saturation is maintained. So sometimes what happens in a chronic bronchitis, if I'm telling my colleague, if someone else sees the patient in PAC and I do the case and ABG is not there, so they tell me, no, madam, the saturation was 96 on OPD on a room air, so I haven't asked for ABG. But it is very important to do ABG because we are not worried about the oxygen saturation. We can always put nasal prongs oxygen. We are worried how much the patient is retaining carbon dioxide so that post-operatively the patient might require non-invasive ventilation or might require ventilatory help to eliminate carbon dioxide. Again, the second ABG, we can see that there is slight increase of PCO2. This also helps us to tell the relatives what could be the prognosis post-op. With slight pain, shallow breathing, slight atelectasis during surgery, this PCO2 might increase and patient might require some ventilatory support. Now here I have written again the same what we said, Haldane effect of oxygen, where we'll have that the oxygen, if you give 100% oxygen for a longer time, thinking that it is a COPD patient, I'm not happy with oxygen saturation of 95, I want more oxygen. Then what will happen? The oxygen will slowly, eventually displace carbon dioxide, and carbon dioxide in the blood will increase, and carbon dioxide will not be eliminated through the airway. Also, we had a classic case many years back where it was a COPD patient who had high CO2 and who had a saturation of 88-90. And we tried to give oxygen post-operatively, a hernia patient, and patient lost his respiratory drive to breathe, and we had to ventilate the patient for 3 days. So remember, it is not don't try if the patient has baseline saturation of 88, don't try to overzealously treat it to bring it to 98. We are okay with 91, whatever, 1 or 2 liters per minute of oxygen. And for every 10 millimeter increase in PCO2, the bicarbonate increases by 1 milliequivalents per liter in acute condition. And in chronic condition, for every 10 millimeter increase in PCO2, the bicarbonate increases by 3.5 milliequivalents per liter. That is the renal compensation. As I said, if the PCO2 is more than 50, you know the prognosis. Also, when to give oxygen, supplemental oxygen, if the PO2 is less than 55 or saturation is less than 88. Now, PFT had a peak 10 years back, but over the time we see that PFT is not usually advised by anesthesiologists. Only if there are following conditions, then PFT is done. If a patient has severe chronic pulmonary disease, where the patient has dyspnea on exertion, which is not cardiac, patient has some chest wall or spinal deformities, morbidly obese patient, obese class 3 now, age more than 70, and a debilitated patient, patients undergoing thoracic surgeries, and a presence of respiratory symptoms such as cough and wheeze. Why it is not done? Because we assume that the patient could have a high peak inspiratory pressure, and now with modern anesthesia machines, we can always shift to pressure support ventilations or pressure control ventilation. But still, PFT has its own value where we find out the force vital capacity in these patients of chronic obstructive pulmonary disease. What is happening? There is blockage of the airway because of secretion and trapping of the air. So naturally, the force vital capacity is decreased. And how do we compare it? We find out the force expiratory volume at the end of 1 second, and we find out this ratio. So we find out that FEV1 to FVC, if it is less than 50%, then patient is going to have perioperative pulmonary complications. Again, this is a chart which tells about the obstructive and the restrictive, how the FEV, the forced vital capacity, and the FEV1 change. Remember that in restrictive lung disease, what happens? Both are so much decreased that the ratio is not much altered. But in obstructive, you will find that FEV1 is more decreased than FVC, and hence the ratio is altered. Again, the flow volume loops. I remember 10 years back, we had one at one hospital a hi-fi anesthesia monitor which showed, I think G monitor, which showed the flow volume loops, which was actually good. If you would find out whether it was obstruction or whether it was outside restrictive of lung disease. And hence, just to summarize, where you have the expiratory curve, the inspiratory curve, if there is reduced peak flow and scoop out, then it is obstructive lung disease. And if overall there is reduced volume, then it is restrictive. Now, classification and all for the postgraduate, and for us to understand how much is the severity of disease. But as we said, if the FEV1 is less than 50%, somewhere between 30 to 50%, then it is gold classification 3. And the patient is at very high risk of pulmonary complications perioperatively. We ask patient to stop smoking. If at least not for 7 days, then 12 to 24 hours or 48 hours. We defer surgery for 2 days so that carboxyhemoglobin levels normalize by 2 days. And ideally, it should be 4 to 6 weeks where the lung capacities and volumes, PFT, will increase. So this is the perioperative goals till now, what we discussed: cessation of smoking, dilatation of the airways, which is necessary, whether it is a chronic obstructive disease, an asthmatic, or an interstitial lung disease where the external pressures are affecting the airways. Loosening and removal of secretion. So you should know what the patient is on. Then eradication of superadded infection, recognition of core pulmonary and treatment. Sometimes they may require diuretics. Improved strength of skeletal muscle. Now, a few years back, 4 to 5 years back, we had this term called as prehabilitation, which has come, which is very, very important. And we are in coordination with our orthopedicians, especially to start something called as prehabilitation of the old debilitated patients. What happens there? If you increase the strength of the skeletal muscles by nutrition, by exercise, or by deep breathing exercises, chest physiotherapy, then we can see that there is less chances of atelectasis and postoperative pulmonary complications are decreased. Again, correct electrolyte imbalance. Usually there could be hypokalemia and hyponatremia which is present. Counseling of the patient, you should understand that all these respiratory conditions, patient is afraid that postoperatively he might land in ventilator. So it is very important that you counsel the patient and ask him to do pre-operation breathing exercises. At least for last 7 to 8 years, we have been prescribing incentive spirometry, which was initially the cost 350 rupees, maybe at 500 rupees. And at least there are some deep breathing before the operation. And check whether supplemental oxygen therapy would be useful perioperatively. As I said, if PPO2 is less than 55 or saturation less than 88, what happens when we give supplemental oxygen? See, if there is increased, what happens if there is decreased oxygen? The body, the COPD patient, he tries to increase his respiratory rate to get more oxygen. But with that, what happens? Increase more respiratory rate, more alveoli, more have air trapping. And because of the more air trapping, again, he becomes more dyspneic. So if you give him supplemental oxygen below 88%, then his respiratory rate settles down. He doesn't have to breathe fast to get oxygen, and hence the air trapping decreases or stabilizes. To check whether the patient will require BiPAP or CPAP perioperatively. Now, anesthesia management. Of course, we all do this every day. Preoperative nebulization. Remember to add a bronchodilator and a steroid. Perioperative steroids are not recommended, but initially our physicians used to write perioperative hydrocortisone. Now they don't write, but we still, if you feel the patient is in acute phase and requires an emergency surgery, you may proceed with perioperative steroids. If there is call pulmonary, the patient could be on diuretics. Then prefer regional anesthesia. Epidural and paravertebral blocks are preferred. Remember that there are concerns during regional anesthesia. We cannot give a level above T6. Why? Because the lower muscles, respiratory muscles could be affected. But now we see that, in fact, in my institute also last month, a very bad COPD patient was there, and we gave a segmental spinal at the level of T4. So here, the surgery should be of short duration. The surgeon should be very quick, and like it was lap cholecystectomy. So we have an advantage of reverse Trendelenburg position. Otherwise, you should wisely choose and try to avoid subarachnoid block level above T6. Interscalene block may not be advisable in COPD patients and patients with respiratory diseases because there is always a chance, how much ever you avoid, there could be chronic pulse. Now, whether to do open or laparoscopic surgery. Some people believe that there is a school of thought that if you do laparoscopic surgeries, the pneumoperitoneum will cause compression on the lung and there could be atelectasis. But remember, the duration of surgery increases. And as the duration of surgery increases, even the supine position will cause more VQ mismatch and more atelectasis. And more bigger the incision, the pain will be there. So you will have to give more painkillers, more opioids you give. Again, the respiration will be depressed. If you give less opioids with pain, there won't be deep breathing. The patient won't be able to bring out secretions post-operatively. The wound healing will take time and recovery period will be delayed. So, topic surgeries with controlled pressures and position can be managed. Then, for general anesthesia, remember it is more than 3 to 4 hours. It decreases surfactants, mucociliary clearance, macrophage function, and increases alveolo-capillary permeability. Principles of general anesthesia during pre-oxygenation. It is very important to give a CPAP. When I am holding a 100% oxygen mask, I always turn the APL wall to 5 or 10 centimeters of water so that I am continuously giving CPAP to the patient. Then, to attenuate the laryngoscopic response, I always give lidocaine in the dose of 1 to 1.5 milligram per kg. And in fact, after pre-oxygenation of 3 minutes, when I start nitrous oxide, I always start sevoflurane, volatile anesthetic agent, which cause bronchodilation. So we should try to decrease the hyperreactivity of the airway and give an increased dose of the induction agent. Try to avoid atracurium, which can cause more of histamine release. Try to use vecuronium and cisatracurium. We all know lung protective maneuvers where we use tidal volume 6 to 8 ml per kg. If peak airway pressures are high, shift to control ventilation. And always try to keep expiratory time more than the inspiratory time so that there is inspiratory time is short. What will happen? The peak expiratory flow rate becomes high and hence there is improved ventilation and expiratory time is more. So whatever trapping of air is there, that is not there. PEEP, do not keep PEEP more than 4 to 6 in this chronic obstructive lung disease. Why? Because as we know that because of the narrowing of the bronchioles and because of secretions and inflammation, we have air trapping, and because of air trapping, they have intrinsic PEEP. So it can add to the PEEP, intrinsic PEEP. So do not increase the PEEP more than 6 centimeters of water. If there is hyperinflation, careful with the use of nitrous oxide. Fluid therapy should be restrictive. Again, there was a debate that it's a hyperreactive airway, whether we should use LMA or endotracheal tube. If you have a surgery, general anesthesia surgery, try to use second generation supraglottic device. It is of course advantageous over the endotracheal tube where you avoid giving more stimulation to the airway. But you should be always careful that, see why second generation LMAs or supraglottic airways, because they have a high ceiling pressure. Whatever, if you're using pressure control ventilation, you can use through a ProSeal ventilation, to a ProSeal LMA and not through a classic LMA. And hence, the second generation LMA should be preferred. And some prefer deep extubation. Do we really need to go through this intraoperative bronchospasm? Because we won't have time for discussion. Deepen the plane of anesthesia, give muscle relaxant, maintain oxygenation, salbutamol spray, hydrocod. This is all what we do routinely if there is a resistant bronchospasm. Hydrocard, magnesium sulfate is being used. You can give, if you feel suspect pulmonary congestion, you can give furosemide. In resistant cases, you can use methylprednisolone. Adrenaline can be given IM or through the ETT or intravenously in titrated doses, and nebulization through the circuit. Operatively, we should remember in a routine case also, it is better to do lung recruitment maneuvers where we inflate the lungs every 30 minutes for 5 to 30 seconds to a peak pressure of 30 centimeters of water. But in these patients should be aware. Of course, asthmatic patient, the same guidelines should remember that they have more of inflammation and more of narrowing. So which is reversible and which should be treated preoperatively. Goals should be minimize airway manipulation and irritation. Again, bronchodilators and steroids preoperatively. LMA can be preferred. Then interstitial lung disease. There are some markers of poor prognosis in interstitial lung disease and the 6-minute test. So anesthesia strategies. And of course, in acute respiratory infections, we should try to postpone for 2 weeks. If emergency, then avoid regional. One more thing in interstitial lung disease, remember, whatever the surgery, try to give regional anesthesia. Even if it is MRM, try to do under thoracic epidural because they have very high mortality with mechanical ventilation. Postoperative care, chest physiotherapy, deep breathing exercises, incentive spirometry. Thank you very much.